Nazira Dawood. I'm the Health Promotion Program Manager. I'm not going to ask you how you are doing today, because I want you to ask me how I am doing today. Yeah? Okay. I'm very excited for me, but very nervous for you. Guess why? I've never sung in my life, but today I'm gonna sing. So now you know why I'm nervous for you, right? But the twist to it is we have the whole team, amateur singers, singing for you today. So let's hear the team. That's a special presentation from the Asthma Coalition team. Come on in.
Okay, you ready?
Yeah.
Here we go.
Old folks, young folks, everybody come. Join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before. When the baby went wheezing and your doctor scratched their head, consider adding dust mite covers to your baby's bed. Dust mite covers can protect them from allergens, you see. Your baby can breathe easier and keep you worry-free. Old folks, young folks, everybody come. Join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before. Her home was full of carpeting and Joan was feeling down. She lost all her energy and often wore a frown. Then she cleaned all her carpets and vacuumed all her floors. Now Joan is feeling better than she ever did before. Old folks, young folks, everybody come. Join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before. Symptoms had John worried, he troubled breathing air. Medication wasn't helping and his leg more taking care. Then he bought a better filter and installed it by himself. Now he's dancing around his unit like an energetic elf. Old folks, young folks, everybody come. Join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before. Willie's fighting moldy spots, he felt he couldn't win. He sprayed them down with Clorox, they came right back again. When he said he knew better, fire up to auto drain, and he hasn't seen the spots again, even when it rains. Old folks, young folks, everybody come. Join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before. Nazira put us up to this, it's her you have to blame. She likes to mess around with us and watch us act inane, but the message is important and the invite is sincere. So please join the coalition and make life better here. Everybody come, join the Asthma Coalition, have a lot of fun. Please park your cell phones and inhalers at the door, and we'll tell you asthma stories like you've never heard before.
Thank you.
How many of you believe in going green? I need to see raise of hands. How many of you believe in going green? We are going green too. If you look in your folder, you'll see a green form. That's the evaluation form. So we need you to complete it before you leave. And you have to give it back to us so that will prove that we are going green. But if you do take it with you back, the scanner outside will beep. Go ahead and try. 9 most dreaded words in a sentence in the English language. No, you know that, Richard, already. Anybody else? No? No guesses? We are from the government and we are here to help. That was Ronald Reagan. But the times have changed, right? And we've all convened you here today, committing ourselves to working together to improve the quality of life of our children and residents in Fulton County. I would like to thank the whole team wholeheartedly. My health promotion team, thank you so much for putting up with me. and helping us getting through successful summits and information sessions for residents and community members. So thank you so much again. We also want to honor coalition co-chairs and the board members of the coalitions. So in the interest of time, I'm just going to ask them to come quick to the stage and get their plaques, just because we want to move to the meat of the program. So thank you so much for your time and consistent participation in bringing communities and convening communities together for a cause. Thank you, Mel, Jeffrey, Janella, and Richard for your participation. Thanks so much. The session today and in the future is not about us. It is not about our accomplishments in the past 2 years, but it is about Brennan Passens. It is about Kellen Bolden. These are our asthma poster children who helped us drive. They've helped us drive this force. And about the brave parents of Brennan Passens, Sarah and Tim Passens. I'm sorry, and the impact of asthma in everybody's everyday family's life that sometimes we don't get to see. It's about the unspoken voices who remind us every day that we have no time to waste. Today we're putting the pieces of the puzzle together. We may not have the puzzle solved today, but at least we've brought it to the table and we can find what the missing link is and put it together. This morning I have the pleasure of introducing our panelists. For interest of time, you can see their bio in the folder. But as they come up, I am going to give you their fun facts that you might not know otherwise. Dr. Ramey, Rebecca Ramey, and guess what? Both the time it was boys. Thank you, Dr. Rebecca, for being here today. Sarah Passens, is also a licensed real estate agent and has a passion for interior decoration. Thank you, Sarah, for being here. Margarita Gonzalez, you can see her bio in the folder. She worked as a project coordinator in the Middle East. Middle East, it was so hot that her daughter and she fried an egg on the pavement. Wow. Asthma Coalition co-chair, and guess what? She's taking riding lessons at the Harley-Davidson motorcycle. I didn't know that. Okay. Richard Johnson. He spends half his time thinking, I used to be able to. And the other of his time thinking, I can't believe I can't. Sarah Lovelace. She's passionate about helping children live their best lives and foster their own feelings of self-worth. She believes this in turn can help them from a very young age to take ownership over their life. In 2011, one thing about Lynn is she is like the ultimate dress up. She dresses up the latest fashion. So when she got awarded for the Georgia School Nurse Administrator of the Year in 2011, she didn't even know. She was just dressed in a t-shirt and jeans. So she was more than surprised. Oh no, how am I dressed? I'm not dressed for the occasion. So that was a surprise for her. She is scared of spiders, but try not to be so in front of her daughter. Finally, Commissioner Emma Darnell. She is, you'll hear more about her, but she is the spark of why we are here today. Our change agent within the system who's allowed us to convene and improve education awareness. She got re-elected recently, so that's a fun fact. So each of us today has a job here to do, right? My job is to talk and yours is to listen. The challenge is for me to finish my job before you have finished yours. I was just being funny. Commissioner Darnell, thank you for being here. Commissioner Darnell, they say it takes only one to start a movement and create a positive change. In 2012, you sponsored a resolution directing the county manager and the health services department to develop an asthma coalition control plan, action plan to address asthma-related disparities in Fulton County. Can you give us a little bit more detail of why you chose to do it?
And thank you very much, and let me just say that we do appreciate so very, very much the dedication and the energy and the commitment of our staff and all of the representatives of our important community institutions who are here today to help us deal with health disparities and help us to deal with all of the conditions which we have been advised by as the basis of this problem. 3 years ago, we were advised by our staff that the community's concern regarding the incidence of respiratory disease in certain sections of District 5 in Fulton County, which included Northwest Atlanta and Southwest Atlanta, that the incidence of asthma, emergency visits of children to hospitals, and other metrics were higher in that district than in any other area of Fulton County. And because it is my belief that public policy should be based upon evidence and data, we asked the Department of Health Services to do an assessment, a health assessment of that entire area. Of course, folks were already planning the design of the building, but we thought it might be helpful to try to understand the problem first. And the health assessment, the data collected by the Department of Health Services, confirmed and convinced the Board of Commissioners that there was a target population within Fulton County that had a disproportionate incidence of asthma and other respiratory diseases. Working with the community, we developed recommendations to the board that in addition to the usual excellent public health initiatives in the area of prevention and education, that we would focus on asthma because of the devastating effect, disproportionate effect that it was having upon children in an area that covered over 200,000 people.
Thank you so much for that response. And you can see where we have, because we had the political will to make this happen, we were able to build the coalition and educate and use with limited resources, we were able to move forward.
Absolutely. I would emphasize the word coalition.
Okay.
Government, community, and professionals.
Great. Sarah Passons. Sarah, you looked at the press release right after Commissioner Darnell passed the resolution, and he called my office, and he introduced Brennan to us. Since then, she's become our poster child for the Asthma Coalition. Many of us here don't know who Brennan is. Can you tell us who she is, and if she was here, what would she want to tell us?
Brennan was my 11-year-old daughter. I have 2 children. Were diagnosed with asthma at an early age. And both my children were active, healthy, fun-loving children. And Brennan was especially kind to people and interested in learning about other people. She enjoyed the arts, and she enjoyed music, and she enjoyed her school and her classmates. And she was just a normal, fun-loving kid. And Brennan, unfortunately, passed away very unexpectedly from an adverse reaction to a medication that she was on as a preventative medication for asthma. And that has obviously turned our lives upside down and been an eye-opener of a sort no parent wants to go through. Nobody wants to rush their child to an emergency room the first time because of asthma and not come home without that child. And nobody wants to be the mother of the poster child. Nobody wants to walk through their home and look at a picture hanging on the wall and say, this is what's left now, my memories and my pictures. And I think if Brennan had survived that night, I think Brennan would be fantastic at sitting up here talking about the night she almost died. I personally hate public speaking, sorry. I'm not good at this. I get too emotional, and it's too raw still. It's only been a little over 2.5 years. But I think Brennan would love to stand up for children her own age and all children and talk about her experiences of asthma from the beginning until the night she almost died. I think she would like to educate a lot of people that cared for her, a lot of parents who are caring for their children just like I was and my husband was. We thought we had everything under control. We went to our doctor visits, we refilled our medications. You know, we were referred by one doctor to another doctor, the top doctors in our area in the northern suburbs of Fulton County. So we thought we were doing everything right. And we learned a lot since that night. There's a lot more to be learned about asthma and about the seriousness of the disparities. A lot of us let our guards down in beliefs that as long as we have a rescue inhaler with us, we'll be okay, or we'll make it to the hospital on time. So our focus has been to educate parents on the 911s of the action plans, what to do when you get to that point that you're calling 911 or you're carrying your child to your car and driving as fast as you can to the closest emergency room, even if it's only 5 miles away. You might not make it. There might be more you could do. I suffer with that on a daily basis. What else could I have done? How could I have been better prepared? How could I have known what to expect, what to look for if this was more than just tightness of the chest and wheezing and her rescue medications weren't working. So for us, that was huge. In the over 5 years that she was on one particular medication under one specialist care, there was never any discussion of if that inhaler doesn't work, what to do while you're waiting for an ambulance, or if you're driving to the hospital, what to do before you leave that house. So that's been our main focus, is to try to push that asthma action plan a little further and open everyone's minds to the 911 zone.
Thank you so much for your insight on this and for sharing, Sarah. We are here to support you. Thank you. Dr. Ramey, you're leaving at 11:30 this morning, so I'm going to pose this first question to you. Is it asthma or asthmas? Because asthma means different things to different sector of people. For some, never visited ER. For some, always at the ER. As a pediatrician in the emergency department, can you tell us what the typical cases that you see on a typical day or night?
Well, I'm not a primary care provider, so you would think that I wouldn't provide primary care, but a lot of times I do. And I think that's one of the biggest problems is that a lot of these kids don't have access to good primary care, so they don't know how to take care of their disease. And so we see a skewed population of kids that come to the emergency department that don't know how to take care of their asthma. And you'd be surprised how many times a day I'll see a child who's using their preventer med as needed, or they're using their albuterol every 2 hours and didn't realize that they needed to be at the emergency department a long time before that. Or they'll be with one parent for the weekend and not even have their meds with them. So again, I see a very skewed population, but I think that it would be, if more kids had access to better primary care, then a lot fewer of them would end up in the emergency department.
Thank you. Richard, children all over the country suffer from asthma, and while medication can help with symptoms, the best defense is to eliminate the triggers that cause the attacks. You've been co-leading the Asthma Coalition the past 2 years. The coalition had weekly discussions over several months before deciding what things to move on with or what to focus on. What things did the coalition decide to focus on and why? Can you use the mic closer to you?
You're going to pick it?
Yeah.
In the early weeks, we spent a lot of time discussing all kinds of points of view. And one of the things that we talked about early on was eliminating the areas that were already, we felt were very well covered. We recognize that a coalition has limited resources and limited ability to interact with the community. And so we wanted to focus on some of the things that maybe were otherwise not being dealt with other places. For instance, the drug companies have spent billions of dollars advertising their medications for asthma and for allergies and things that are related. Many people knew where to find their doctors, although certainly it could be more open and all those things, but that was something that others were working on. And they've spent trillions of dollars in the last 50 years cleaning the outdoor air. So while the last 50 years has brought us great strides in all of these areas, asthma has increased by nearly 400% over that period of time, where all of these capabilities were being expanded and worked on. So we eventually asked the question is what's not being done and what a small group of volunteers with no funding and little time could focus on that could make a meaningful difference to asthma and the supportive stakeholders that are involved in asthma care. Research supported the conclusion that the indoor, where people spend 90% of their time, is a potentially serious problem for asthmatics that's not being well understood. It's not heavily focused on by the medical community, and it's underserved by the public sector. It sounded like a good idea to us for being further consideration for focusing on the indoor air. Once we narrowed our thoughts to the indoor air through discussion, we organized most of the common asthma triggers that would be affected by indoor air into airborne triggers, surface triggers, and the humidity control. In the home, the remedies for these concerns are mostly family self-management issues. And they require little capital, but some understanding. The asthmatic self-management before emergency intervention is required, fit neatly into that package. So we included as the fourth element that we were working on, the making sure that people knew, had a good asthma plan, and knew when to seek emergency care when necessary, but how to head it off before it was necessary.
Thank you. Can you all hear from here? Can you hear the panelists? Okay, if you can, please let us know. We'll try to increase the volume. Sarah Lovelace, you are the nurse case manager and the high-risk asthma coordinator at Georgia Pediatric Pulmonary Associates. What does that typically entail? And should we consider every admission of asthma as a significant event or a failure of medical care? How do we improve the standards?
Sure.
Can you take the mic towards you? Yeah, or speak close. Yes,
Better.
thanks.
Okay. At my office, Georgia Pediatric Pulmonology, we're the largest pediatric pulmonary group in Georgia, so we see a lot of asthma. And we developed a high-risk asthma program that right now has about 500 children in it. Kids get into that program a lot of times based on whether they've been admitted to the hospital, the ICU, multiple emergency room visits, been on a lot of very high-dose inhaled steroids as well as systemic steroids, prednisone, or things like that. The goal of the program really is to partner with families, primary doctors, emergency rooms, to sort of tie loose ends and communicate about the child's asthma care. Again, like Ms. Passon said, working on the asthma action plan and sort of making it a little more real for families, how to implement it, what does it mean. We, like Dr. Remy, we see a lot of kids and families that need a lot of education on what to do on a day-to-day basis with their asthma, as well as when they have an exacerbation. So the high-risk program involves a nurse that calls monthly and talks to families. And really, I have found that asthma education is really important, but building relationships with people, parents, children, is just so critical in getting your point across. So, and you asked about asthma admissions. Every asthma admission is important and matters, without a doubt. We actually do something now called an asthma hospital quality review, where we sit down as a team with doctors, nurses, parents, and we go over a lot of the key elements of the admission. And I won't go into all the details of that, but the bottom line is we sit down about every single asthmatic child, whether they're in the high-risk program or not, and we talk about what got them there, what got them to the emergency room, what got them admitted, and we look at things that we can do differently to change that and stop it from happening again, and we look at things that the family can help us do as well.
Great. Before we move to the next question, I would like to give a shout out to Dr. Matthew McKenna. He's our medical director at the health department. And I'd like him to let us know what he expects to learn from the session today, quickly. And I'm coming to more of you. Next might be your turn.
Well, first of all, I just want to say thank you to the panelists for being here today and educating all of us as well as me about the ins and outs of asthma. We've had a model for understanding this in terms of looking at it as a three-legged stool: the outside air quality, the inside air quality, and medical care delivery. And it's really exciting to me to be able to hear from all these different perspectives about how we can make each of those stool legs a little bit stronger in terms of addressing this issue. It's also exciting to me because given the breadth of, so to speak, no pun intended, but given the breadth of the various people involved in outside environmental air quality, housing and inside air quality, and medical care, we have an opportunity to hear from a large number of different types of people with different expertise. So I always learn something from that, given that I'm, classic kind of medical doctor, to hear the other perspectives that will be brought forth today. So that's what I plan to learn and excited about hearing.
Looks like you were prepared. So, Danella is our other Asthma Coalition co-chair, and Danella, you're a pharmacist. Pharmacy is the vital touch point before a person gets to their home. How does selecting a pharmacy provider impact health outcomes? You're also leading the Asthma Coalition, specifically the treatment committee. What is the goal of that treatment committee, and what have you accomplished so far? And how do you feel better placed as a pharmacist in convening the healthcare providers to improve quality outcomes?
Okay, you gave me 3 questions rolled into one, so guys, if I don't remember the 3, you help me remind me. First and foremost, being a pharmacist for 21 years and not practicing pharmacy in the traditional sense, but managing over 60 pharmacists, it's very critical that you leverage me appropriately, because pharmacists as a community-based model oftentimes is where that patient who is not well controlled is going to go to for some added care. And speaking and listening to the passings, I do recognize, and you medical people in the room, providers in the room, we should all recognize that integration of care was non-existent when we think of Brennan's demise and what we could have all done to prevent that from occurring. So I think it's important as it relates to being in the pharmacy space that I educate pharmacists. I begin to give them newfound awareness of how they can improve that patient-provider relationship, almost serve as a navigator of care when they recognize key breakdowns in an asthma plan or a treatment guidelines, that they take the time to stop what they're doing and to connect that provider with that patient's needs. I think that's critical. If we do that in the pharmacy space, you will see a decrease, hopefully, in the space called ER visits. So that's one component. The second question, I think, was, as far as the treatment committee, what's our goals and what do we hope to accomplish? For me, as a pharmacist, I always hear from the various providers, who they're connecting with as it relates to improved health outcomes. I didn't hear about the school. We got Lynn here today to talk about that. But I always think we miss the opportunity, if we're thinking about integrated care, to leverage the community pharmacy. In the downturn where there were losses of jobs and no one had health care, people use that community pharmacist almost as a segue or this pseudo healthcare provider, primary care provider, to address some of their concerns that maybe they would address in the emergency room or in a healthcare provider space because they didn't have the insurance to pay for that visit. So if I don't do anything but accomplish this with my presence here as a pharmacist to say we can't talk about care and improving asthma outcomes unless we focus on all facets of the healthcare paradigm.
Great.
And your third question, you did have a third question there.
How are you better placed as a pharmacist to convene the healthcare providers?
I think I can only talk about my company, and I'm not here to represent my company. I'm actually here representing as a volunteer. But I will tell you, at my company, we think about integration. I was just talking to Margarita about integration has to be the way community pharmacies deliver care. We have to find a way to take that pharmacist away from the dispensing role solely into the space where they can talk to Susan and say, if this happens in an emergency situation, this is what you need to do. Do you have an asthma plan? Knowing the school nurses, believe it or not, in the community setting, we should be able to do that. understanding who the emergency room physicians are because we see the prescriptions come through, and connecting those dots, visiting the emergency room, visiting the healthcare providers. We can do those sorts of things. They all have space on their docket to deal with the pharmaceutical companies, but getting to understand the needs of the provider group, understanding the gaps around education, and being able to improve those relationships and those experiences for the patient in the pharmacy setting.
Great. Before we move to the question to Lenny, I do want to recognize Deshaun Industries. Can you come in front, Deshaun? Deshaun has been our volunteer for a year and a half. He's been our volunteer a year and a half, very patient, very composed, has always brought my blood pressure level down because anything up and not right, he knows how to calm it down. You would want him by your side in your team. He is looking for a job, and we know he's been excellent. If you think the Asthma Coalition has come so far, he's a volunteer. He's a volunteer and doesn't want to let go of us because he believes in the cause. So thank you so much, Deshaun, for your dedication and commitment. Lenny, you're from the Atlanta Housing Authority, and people here are wondering, wait, what does asthma has to do with the housing? What has Atlanta Housing Authority done to promote healthy living environments? Can you tell us more about the clients you serve, and what is the process of reaching out to them?
So I wanted to say that I appreciate your invitation. The Atlanta Housing Authority is the largest authority in Georgia, and we provide support for over 21,000 households served. So the Atlanta Housing Authority has been doing a lot to promote the quality of life. Our presence is in the city of Atlanta, although we have some communities right outside as well. We have annual inspections of the units for residents. And these inspections are very critical because we have an inspection team that come in and they provide guidelines for sanitary, for cleanliness, but we also inspect the common areas as well, like leasing offices and restrooms and things that are associated in a community. So these inspections are very critical. Some of the inspections are done by HUD, but nevertheless, the Atlanta Housing Authority, we get the data, so we know how the units are performing. And if the people are not meeting these inspections, we provide a warning and potential termination from the program. Another thing we have done recently is the American Recovery and Reinvestment. It's called ARA. President Obama passed it in 2009, and a lot of these funds went to improve and revitalize some
leading cause of school absenteeism for children due to illness. You and your team already play an important role in coordinating services and provide education to the parents. Can you briefly talk about how you coordinate these efforts?
Absolutely. Thank you first for allowing us to come. And let me just tell you a little bit, the audience, a little bit about Fulton County School System, because sometimes it's confusing with two school systems in Fulton County. So Fulton County School System are all the schools outside of the city of Atlanta. So we have 106 schools and we have an enrollment of about 96,000 kids. So I have a team of 20 registered nurses And then in all of our schools, we have a school-based clinic where we have a healthcare provider, kind of like a medical provider, but it's a medical assistant. My registered nurses oversee the medical assistants in the schools. So with that, what our team does is, and you said it exactly right, we play an extremely important role in the lives of children with asthma. And why? Because if you think about it, kids spend 8 hours of their day, 5 days a week out of 7 days in school. So what we bring to the table is extremely important, and we take that role very, very seriously. So what we do is we first of all make sure, and you've heard some of the panelists already talk about action plans. That's the first thing that we ensure that all of our children with asthma have, is an action plan on file in school. But we don't just keep it in a file, that becomes a living document that we use every day to make sure that kids receive the proper care that they need if they have asthma during our school hours. So with that plan, we actually review every plan. We make sure that kids, according to that plan, have the proper medication, supplies that they need. We also do, talking about education, kids come in the clinic every day to get their medications. So it's a wonderful opportunity for our team of nurses to spend with children going over medication. How do you use your inhaler? And some of the kids say, I know, but we always say, but we want to see you. Let us see you. We need you to be in our sight, so that, again, there's that opportunity for continued education. We also work with the partners in the community, the providers. We make sure, talking about relationships, that we build those relationships with our community providers, because our goal is also to try to help kids stay out of the emergency room. So if there are children that we see that don't seem to be well controlled, my nurses are making phone calls to those kids' providers. But one of the gaps that we talked about is exactly that, the access that some of our kids have to a provider or a medical home. So again, that's where the school nurses come in, because we're trying to help parents find kids medical homes so that their care can be standardized.
Great, thank you. If you note on your table, you see the pink slips. Those are the index cards for you to ask questions. In the interest of time, we won't have people asking questions, but if you can jot down your questions, one of my team members can collect from you and we can pick a few questions. But we'll make sure all these questions are answered when we do send a follow-up email. Okay, thanks. So Margarita, you are more involved in the technology aspect of healthcare system, the IT. Is there a place for innovation? How do we capture outcomes? A patient comes, grabs medication, then he goes to another clinic, grabs medication. There's multiple tentacles working in different directions. How do we track patients in the real world? How do we know their outcomes are improving? It's a humongous task, right? Can you tell us how your department is working in these terms to improve the standards of tracking patients' outcomes?
Okay, well, thank you for the question and thank you for the opportunity. Is this on? Okay, thank you. Sorry. Okay, very important question. So a couple of things, and actually you touched on it just a minute ago. There's a lot of innovation. There's a lot of systems. The problem is they don't speak to each other. And so there's a lack of integration in information systems. Part of that, and I have to say, I'm not actually a technologist. I'm a social scientist by training. I just manage a group of technologists over at Fulton Tech. So we've got some really smart people working on this. The challenge is that a lot of these information systems belong to different vendors. And so the output of those information systems, whether it's the EMR, the electronic medical record, the electronic health record, the personal health record, all these things, the information that goes in is sometimes it's unstructured data, sometimes it is structured, which means that it's field, there's a way to get it in, there's a way to get it out, and these systems are not always compatible. Okay, so I'm kind of explaining it in layman's terms. That's a problem. So you actually touched on the word standard, information standards. That's something that is being taken on at the federal government with the ONC and CMS, Medicaid. I was actually at a really large health information technology conference in February. And I was sitting in one of the sessions and the guy said, this is not your grandfather's Medicaid agency. Like what they're proposing and what they're pushing and the types of projects and initiatives that they're funding are really innovative. The challenge is, again, when all these different providers who are not technologists, you went to medical school to be a doctor, okay? So when a vendor comes in and sells you a solution, they promise you the sky. And then sometimes the solution doesn't deliver, or it does within your four walls, but not talking to the hospital system. So then comes the need for regional exchanges, service area HIEs, that sort of thing. In Georgia, some of you may know, there is a statewide health information network. My team was actually a part of, I'm the program manager, by the way, for the work that we do with the state of Georgia, the Department of Community Health. Along with, we work very closely with Children's Healthcare of Atlanta. So one of the things in terms of tracking outcomes and all that, if you can work with a partner, like for us as technologists, we don't have data that just sits around at Georgia Tech, okay, because we don't have medical school. But we're very blessed to have some really good partners, such as Children's Healthcare of Atlanta, some other physicians here, like outside of Atlanta. So if we can work with them, there's also the need for analytics, so informatics, and you touched on that as well. We can do that, but it's just on that data. There's the issue of marrying claims data, okay, so like Medicaid data or data that Blue Cross Blue Shield has, and then marrying that with clinical data that sits in the doctor's office. Like, that's part of, it's not really been done. And we are all trying to tackle that at state levels, and we're at different levels. And Georgia, we're making progress, but there are other states that have really made some more advancements in that area.
Great.
So it's not just about asthma. I think generally speaking for chronic diseases, this is a challenge.
Great. Christina, research. The health impact of asthma and regional pollutants. You've taken up some of those research yourself and conducted the environmental challenges outside of school, and how does that affect the normal breathing for children? There are still many gaps in knowledge and areas where research is needed. How do we identify the areas that gives the most impact?
Well, first of all, I want to thank you very much for inviting me to come here and speak, and I'm very pleased with the range of expertise that we have here so that we can really engage in these questions. And so I think first of really figuring out what the areas are for research is to really talk to the community first, because they have the most information about what the actual problems are and can help to generate research and research designs that we can get to those questions and then begin to figure out, based on what the research shows, of interventions that can work. And so the majority of my research has been looking at exposure assessments. So that's figuring out where and how and to how much people are exposed to different kinds of pollutants in outdoor and indoor environments. And that feeds into also what you were just talking about, Marguerite, in terms of data and where data is coming from in order to really do these epidemiological studies. Because actually there's some good information that's in your packets here about indoor triggers and also about epidemiology and how we know that air pollution is linked to asthma. It's definitely linked to, there's a lot of support for air pollution from outdoors, especially when we think of particulate matter and ozone being linked to asthma attacks. And there's also evidence showing that it's linked to development of asthma in the first place. So what I think is important is that this information has come from very large-scale studies of lots of children over time and repeated measures on children and following them over time. So I think it's very important for us to try and have linkages of children in different areas and to follow them over time to really be able to understand about development and also on triggers as well. Because we have to think about that there's lots of different triggers in the indoor environment. There's allergens, there's mold, there's pollution indoors, and then also outdoors. And the triggers for a particular child are different. And in terms of asthma action planning, they need to know what are the triggers for my child. And in research, we want to be able to look at the range of that and then how we can prevent those.
Great. Sandra Jones, I came to you on purpose asking you this question to you in the last, because after all is said and done, it boils down to the person living with asthma. We're all health illiterate at some point at certain stage. So you can imagine a person visiting a physician, going home, taking the prescription, had no idea when the doctor said eat it 3 times a day after food. Does he eat it all at once or after every meal, right? He takes the prescription home, has all these stresses going on, kids, wife, husband, job, places the prescription somewhere else. It's all about health literacy. How can you tell the audience here how important health literacy is in relation to asthma, and what are some recommendations regarding health literacy for healthcare organizations and even healthcare providers with different cultural contexts, language barriers? How do you connect those mismatches in a perfect storm?
Wow. Thank you, first of all, for this opportunity. Let me just kind of set the stage here, or the picture around literacy in this country. There's a National Assessment of Adult Literacy, and they do a sample size in this country of about 19,000 individuals from ages 16 to 60. And the purpose of that is to get an idea about the literacy of the Americans. And they also measure health literacy. They do this about every 5 to 10 years. And one of the things that they found is that about 78 or 90 million people in this country are challenged with health literacy. Now, what does that boil down to? Well, you've got about 1 in 5 adults read at about a 5th grade level. You've got, or below, on average, American reads at about the 8th or 9th grade level. And yet most health materials are written at about 10th grade level or above. Now let's just bracket that for adults. If you take children and adolescents, literacy with that age group is just in its infancy. But if you look at the national report card around adolescents in this country, about 26% of them read at about the 5th grade level. So you factor in that most asthma kids missed an extra 1 to 3 days beyond the normal kids. I don't want to say normal, but kids who do not have asthma. So you've got a nice pot of stew there for families, for providers, for pharmacists, for school nurses, for anyone who are in constant contact with kids and adults who are trying to manage their asthma. If you look at a lot of the health materials, and it has great intentions of trying to help families manage their asthma. But if you're struggling, and I volunteer and teach adults how to read, there are many people in this country who drop out of school at 3rd grade, and they can't read. And you're not going to find too many people, at least in my experience, because there's a lot of shame there. Or there's an assumption that because Sandra, and by the way, I have a daughter who has asthma, she's 30 years old, the assumption is that by the fact that they're coming to the healthcare system all the time, they know what to do. They know how to manage their asthma. But it takes a lot of courage and a lot of humility to say, I don't understand, I don't get it, I've tried everything I possibly can. So what can we do? There are tons of efforts nationally that are going on. Number one, the Institute of Medicine has identified 10 attributes that a healthcare organization can have that starts the conversation that can bring about changes in operations around health literacy. One of them is to look at their policies. Another one is to look at their materials, professional development for their staff. You want to put it on the radar for them to be aware and cognizant of the fact that we are seeing patients with chronic illnesses. Are we doing everything we possibly can to improve their health outcomes? And by the way, literacy is probably one of the most strongest predictor of health outcome. Beyond race, beyond economics, beyond culture, okay, literacy. There is a national action plan put out by the Department of Health and Human Services, and they identify strategies, goals that organizations can do to address health literacy. The last thing I want to say to you is this. that according to the Center for Healthcare Statistics, a disproportionate number of minorities and immigrants are estimated to have literacy problems. 50% of Hispanics, 40% of blacks, 33% of Asians. So just think about that as you think about the clients that you're serving and seeing in the emergency room, in school-based clinics, in the classroom. And you might say, and then I'll stop, well, the teachers are there. They can provide health education to the students. Well, that may be true, but there are studies to suggest that there is a variation between addressing health topics in Minnesota and Georgia, or New York, or Iowa. The standards are there, but the implementation of them varies tremendously.
Great. I know Dr. Amy is getting ready to leave, but before she leaves, I just have a couple of minutes question for her she can answer our question. Smoking and secondhand smoke are a well-known triggering factor for asthma, but recently the hot button topic is obesity and asthma. Can you elaborate on that?
Yeah, there certainly seems to be a correlation, and we don't know if that's because the children with asthma are more prone to being less active and become obese because of that, or because obesity itself contributes to the severity of their asthma symptoms. Obviously, obese children have more difficulty breathing, and it can also cause obstructive sleep apnea, which can certainly exacerbate symptoms. But we know that there probably is a significant correlation, and then of course, if a child has to be on steroids frequently, that can make that problem even worse.
Okay, thank you. So I know you're getting ready to leave, so thank you so much for being here, offering your insights and expertise. Let's give a big hand for Dr. Amy. Thank you, Dr. Amy. Okay, you have some additional. Okay, let's keep the comments and answers to 2 minutes since we're coming to the end of the session in 45 minutes, but there are more questions to cover. So Christina, go ahead, and then I'll go to Commissioner Darnell.
So I just had a couple of comments and additions in terms of particulate matter. So I'm not sure if people know what particulate matter is. So particulate matter are either solid particles or liquid droplets that are in a gas, so the gas is air. So they can be solid or they can be liquid. And in terms of research and policy, it's true that air pollution in general, outdoor air pollution, has been going down all across the U.S., which is really great. But in the case of Atlanta, we're still out of compliance with the EPA standards currently for PM and for ozone. So I think in terms of research, it's really important to look more at composition. We started out just looking at particles in total and counting their mass or how many numbers of them there are. But it's becoming increasingly important of figuring out the actual difference between indoor and outdoor air pollution and what the pollution is actually composed of, because it seems like there are different health effects. And we need to have more studies that are focusing on that. And I think it's easier to do that with the outdoor environment. There's more research in that area because we have outdoor air quality standards that are set by the EPA. There are no current indoor air quality standards, although there are some for occupational health. And so in terms of really cleaning up the indoor environment and really looking more in depth into the parts of indoor air, which are most important to asthma, having more inputs or maybe even a pressure perhaps for having indoor air quality standards may be something to consider in the future. I don't think that's being addressed at all, but I'm sure it's probably has been discussed.
Great, that leads us a great segue to Commissioner Darnell. This question about why do you take up initiatives that no one else does? That way, good, in a good sense, because you're like the change agent. On July 17, 2013, you passed you voted to amend the Fulton County zoning resolution to promote environmental justice and protect environmentally stressed environments. That ordinance was one of the kind in the entire nation. So why and why?
I think that the explanation for the policies which the Board of Commissioners has developed in an area which we refer to as environmental justice, those policies are based upon both the legal and moral responsibility which we have as a government to protect the health and safety of all people. Therefore, this area which I see you have emphasized in your literature, this area of health disparities represents a major challenge to public institutions. The National Association of Counties has adopted a policy of, and I quote, zero tolerance for health disparities. And the Board of Commissioners has adopted that as a goal, zero tolerance. It is not acceptable as a matter of policy that certain groups would be sicker than everybody else and die earlier than everybody else. That can be important data in the laboratory, but in government, it is a situation that has to be eliminated. We have to show people who pay taxes that we are moving toward the reduction and the elimination of health disparities. And you have pointed out in your literature that one of the factors affecting the incidence of asthma and asthma mortality, and I have some of the highest asthma mortality rates in District 5 than anywhere in the county. One of the factors affecting asthma mortality among both adults and children, you say ethnic differences in asthma prevalence, morbidity, and mortality are highly correlated with poverty. And it continues on with urban air quality and indoor allergens. To respond directly to Dr. Daywood's question, Board of Commissioners adopted a policy that if a minority or a language community has an environmental stressor within their area, no use permit or no zoning modification involving what health services has defined as an environmental stressor can be approved within 1/2 mile of the property line of that community. The policy is based upon data developed by the Green Law environmental law firm, which was a study called Patterns of Demographics and Pollution, where they studied the 18-county metropolitan area to discover where were the areas that had the highest concentration of environmental stresses in minority and language minority communities. And to our shock and surprise, we found out that of the top 5 counties in the 18-county area, Fulton County had number 1 in the area near Douglas County and the Fulton Industrial Boulevard line, and number 5, located near the quarry on the belt line. So when this data was presented to us showing that we had the highest concentration of hot spots in Fulton County than in any of these 2 areas, top 5, the whole 18-county area, then the environmental justice distance requirements were established. How did it happen? It happened based on public policy. It happened because it has been the land use policy historically in Fulton County and in counties throughout this nation to zone environmental stresses in minority communities. There's a reason why there's the highest concentration of companies on EPA's toxic release inventory list are located on Fulton Industrial Boulevard. There is an explanation. Public policy is what places particulate matter in some areas more than others. So we take the position that if public policy created the situation, then public policy can and will correct it. No, asthma doesn't just run in families. According to this report we received, it runs in decisions by people we elect to make decisions for us. That's where it runs. And one of the strategies that I would like to see the coalition explore, which has been recommended, civic engagement. Civic engagement. Sometimes we might need to come out of the laboratory and deal with the situation of why is it that the average customer in a pharmacy has a third-grade education. That's what they did back in the day. If a situation that was social and economic or political was creating a situation that was a life and death situation that was costing people their lives, then the community came together in a church under a brush arbor or somewhere and said, this guy just stop. They call that civic engagement now. I'd like to see our coalitions organized around what we've heard here from some of these panelists, some of these external factors, social and economic factors that are creating situations indoors and outdoors where people are dying for no other reason than their ethnic characteristics. I also notice here that there's a gender difference. I never knew that. Females, African American women, that combination, highest number of deaths due to asthma. We're just excited by what we have heard here this morning from these experts. I think it's a fantastic panel. I was trying to take notes, but there was so much good stuff coming out, I couldn't take all the notes. So Mr. Adams, my chief of staff, is here, and I guarantee you he got it all. And my colleagues will tell you on the commission, don't let me hear from the experts. Literacy, health literacy. Yeah, that's what I'm taking away from here this morning. People in that pharmacy, they don't know. They don't know. You know, it's going to take more than panel discussion. It's going to take more than task forces. We're going to have to organize to demand that our governments be more responsive to the weakest among us. Mr. Johnson said he's had asthma all his life. He knows how to control it. He's in a ability to control it. When he goes to the pharmacist, they got to do more than just dispense his medicine. They got to answer some questions. We're working toward that day. And I'm just so encouraged to see, people coming together like this to help us, because we're going to do what we have to do to meet our responsibilities to all the people, even those who have a third grade education.
That's a very great point, Commissioner Darnell. You just don't know that you left the door wide open, because in the next 2 weeks, I believe the Asthma Coalition might come to you with data and ask you to pass policy, so I'm not responsible for that. Sarah Passens, can you talk to us about what is the black box warning? And some of the questions that you've always asked us throughout these past 2 years is, what are the protocols that physicians follow when there's an emergency situation with a pediatric asthma patient? Has it been reviewed? Has it been updated? Why are some kids dying? Are there any trends to improve the protocol? These are the questions you asked, and I know you are the best person to answer them because you've researched more than any of us in this room today.
Sure. With our experience, both of our children were on a medication with a black box warning label, and we were completely unaware of it. We are educated parents. We had educated doctors. We went to one of the largest pharmacies in place, and we were bringing home boxes of medication as preventative meds that had labels on them such as rinse your mouth after use to avoid oral thrush, or this medication will not help during an asthma attack. You see these labels printed out on boxes all the time to tell you to take, with food or on and on. But I've never been given a medication, and this particular medication had never had a sticker placed on a box that said, please read black box warning insert. My doctor never told me there was a black box warning on the medication. The television commercials didn't tell me that when I was sitting in the allergist office. When I questioned the original prescription, what I had seen on TV advertised, I got a general response of, well, the benefits outweigh the risk. Well, for me, today, I cringe, and that to me is just a huge red flag. And any child who is depending on their parent picking up that medication from a pharmacist because their doctor prescribed it, they have a right. I mean, where was my daughter's voice? Where was my son's voice to say, hey mom, did you take out that patient insert, the one that's folded up like 55 times and it's, the size of the US map? Were you able to understand everything that was in there? I mean, we speak about literacy. I think you pretty much have to be pre-med to understand what information is provided. Now, I've read it backwards and forwards since the day my daughter died, and we started on this mission of trying to figure out what happened that night. And I can tell you, there's still times when I pick it up and read it, and I have to Google a word, and then that sends me down another path. Well, what did that word mean? What would that look like? Is that what I saw that night? So there is a disconnect between, the black box warning labels on all medications, not just the asthma medications, but when you're taking home a medication that states this can cause anaphylaxis or this can cause a paradoxical bronchospasm, you need to be aware of that. And you need to know as a parent, and so do the nurses in the schools, that the nurses didn't even know that this was a side effect. I didn't know it was a side effect. I didn't know what that meant. I thought it meant an asthma attack. The asthma attack where you give them the nebulizer, the inhalers every 20 minutes. If need be, you go to an ER. So, there is a disconnect there with the black box warning, and when you see those type of warnings, when the doctors who are prescribing them and the pharmacists who are dispensing them, they need to have a conversation with that caregiver explaining this is what you do when you go into an anaphylactic reaction or a paradoxical bronchospasm. You can't wait every 4 hours to give a nebulizer treatment. You're going to need epinephrine. You're going to need to tell the paramedics, this is what's happening to my child. She's having a paradoxical bronchospasm, or she's possibly having anaphylaxis. I would like her intubated. I would like her to be given epinephrine. I would like her to be given nebulizer treatments in the ambulance on the way to the hospital. I want other medications given to her. Call the hospital for, protocol. And the EMS in Georgia protocols are very scattered when it comes to pediatric asthma patients. So the care is all over the board. I've heard stories in the last 2.5 years of patients showing up in an ER just like my daughter did with nothing but oxygen and a ride. I've heard of stories where children were given epinephrine, bronchodilators in the oxygen, back valve mask, intubated, and were admitted for a day or two and went home. And that level of care really goes back to what we were saying with the whole 911 program, the 911 asthma action plan. A parent needs to know, what can I do to help my child survive this paradoxical bronchospasm or anaphylactic reaction. And there needs to be a checklist for side effects of the medications. Never did any of my physicians, whether it was the pediatrician or the asthma allergy doctor, nobody ever said, here's the list of side effects from this medication, check off which ones you're seeing in your child. Whether it's headaches, joint pains, frequent upper respiratory infections. And yes, how many times have you, since you were here last, have you gone to your pediatrician or to an urgent care because it was a Saturday evening with that side effect of an upper respiratory infection? So there is a huge disconnect there, and I think they can all kind of be tied together with just some conversations and some better tracking and some better protocols in place for that 911 plan.
Thank you, Sarah. These are some unanswered questions, but I'm hoping that the treatment committee, the coalition, can look at it and improve the standards and make sure the protocol is updated so we can improve the ultimate outcomes of families. Lenny, so how do we foster and improve relationships with your agency and partnerships?
So one of the things that I do at the Atlanta Housing Authority, I manage the data sharing agreements with various partners. One thing I do want to mention that has not been mentioned on the panel, housing authorities, they have to comply with the HIPAA rules. And the HIPAA rules specify that authorities cannot collect health information from residents. The best thing we can do, and we have to be also careful, is we can collect health information at the aggregate level, but not at the individual level. So I just wanted to point that out, that there is a challenge with data sharing agreements, especially health information, because of the confidentiality. Certainly if the family signs a release giving permission to give their health information, that's fine. But authorities really do not collect health information. So what we have done is right now we're going through a data sharing process with Fuqua Center of Psychiatry at Emory University. They're very reputable. They are at Wesley Woods. They are nurse practitioners that actually go inside our HA owned communities. We have 11, and they do a mental evaluation and other forms of evaluation of residents. So we are going through this data sharing agreement with Fuqua, Emory University, but we can only get aggregate information, and certainly we don't have the need.
Agreements, if any of the agencies at the table and among the audience are interested in collaborating with you,
Absolutely.
that there exists such an option
I'll
for
be more than
them.
happy to.
And I want to remind the audience to please complete, if you have questions, to fill up in the index cards, and Kara will be coming around to collect those questions. I'm going to have the last 10 minutes for answering some of those questions, but please do know that we'll answer all those questions in the follow-up email also. I want to go through all of the audience, the panelists here. If you can quickly, in 1 or 2 minutes, 1 minute preferably, tell us what is the missing, after all is said and done, the panel discussions, the afternoon sessions, we all go home. What do you think is the missing link or the missing piece of the puzzle in combating asthma to improve health outcomes for our residents? And I want each one of you to answer that question. What is the missing piece of the puzzle? Christina?
So I get to start first since I'm on
Yes.
the end. So I think, so each of us is going to name what the missing piece is and what the important part is to note how we can get together and then put those pieces together. And I think we already understand that each of us has their own piece and that we know and that we're motivated to work together so that we can fill them all in, because there's been lots of pieces that have been said that I haven't even thought about because it's not in my area. So at least in terms of research, I think it's definitely identifying where the gaps are in the knowledge that we have and trying to figure out how to fill them. And filling them is going to be a long process of having these coalitions and discussing what kind of studies are going to inform those research questions, and then designing them and carrying them out, which is difficult from the point of view of the researcher, because we apply for grants and get funding, and then we can do something. Actually being in a coalition and figuring out what questions we need to answer isn't something that's usually funded. So that's starting to be the case more and more, but it's really important to realize also of the challenges that each of us face in answering that question. And that's what it is from my point of view.
It's like the question of what's the answer to world peace? So for me, I'm actually really excited because with some of the requirements with the Affordable Care Act, and especially in information technology, meaningful use, patient engagement, whether we want to or not, it doesn't matter if you're a patient or a provider or where you are administratively, we're being nudged towards greater engagement, greater collaboration, information sharing, that sort of thing. As far as the missing piece, I think it's a matter of, it's not the missing piece, it's actually connecting the pieces. And for me, I like data, and I'm all about like, so what? I think there's a lot of information out there, there's a lot of data out there, but it doesn't always answer the so what. And that's where this movement towards informatics and data analysis of big data, which is like, big systems, and then this little data that Sarah actually alluded to, which is patient-generated data. And so the missing piece is actually marrying that patient-generated data, that claims data, and that clinical data.
Janella.
I think for me is what the passings represent, because we're talking about all the algorithms at a 30,000-foot view, but dealing it and honing it right into families who've been affected adversely by the lack of continuity of care, and to constantly remind everybody based on the senseless deaths that occur, that this is a real problem that Commissioner Darnell discussed as it relates to disparities. And just because you come from a resource-rich community doesn't mean that your health literacy, as Sarah described, supports that you come from a resource-rich community. So we need to take, my request is that you reach out to me, you reach out to Richard, and figure out how you're going to get involved in this grassroots movement. We keep talking about we don't have resources. Everybody in this room is a resource. And that we take this information, not just have it as insight, but we convert the insight into action, and we do something about a very reasonable problem that can be prevented. So that to me is the missing link, the grassroots effort. Thank you.
I think everybody up here today has talked about, and you bring up this great point about connecting the dots, and we've talked about communicating with data. And for me, I would just take it one step further and say unity. I think being united is how you keep this movement going. And taking our unity, which creates a power, and then applying it in action steps every day. So again, as Danella said, every person in here is the resource, is the answer, is the action. And together, if we take steps to get to know the person sitting next to you, exchange information, follow up, continue to get together in this fashion, that is how we create the change. So I would say unity.
A coalition is the coming together of people who perhaps have a variety of dispersed interests in doing other things, but their certain parts of their world overlap. And what we're looking for in the coalition is to bring those people together for that portion of their business that can influence asthmatics. We believe that most of the people who will receive information, many of the families who will receive information will act on it. We also understand, we're not so naive to not believe that there are some self-interest happening in the world, and there's some hidden agendas and other kinds of things that can derail efforts that we're trying to do in terms of getting information out to the community. But it's my belief that the biggest problem that we face, despite all of those things, are people who understand and know this information but choose not to act on it for whatever reason that they choose to do. I'm reminded of an old Native American expression that it's very difficult to wake people up who are only pretending to be asleep.
Well, I don't see any missing pieces. I think this coalition represents the institutions and agencies and individuals that are needed in order to achieve the outcome that we all share, and that is to reduce the incidence, morbidity of asthma. You have community people in this coalition. One of them is from my district. You have research folks, you have educators, you have all of the major institutions represented, universities. But just as we've heard, each one of us is a resource person. And I think that if we understand what the goal is, and that's to have some impact on those numbers, I see it as quantitative. And we're becoming more and more quantitative every day. Do I see a reduction in the number? Do I see a reduction in the number of children from my district that go to grading for asthma emergency? That's what I have to go by. I strongly support one of the strategies that I heard one of the panelists say. We've got to be more effective dealing with the target population. You know, I often tell people if you have some weaknesses in that area, maybe you should be working at Lockheed on planes. Because you don't have to develop any communication with them whatsoever. To go to work, get your plane and go to work. When you deal with people, the people who've been marginalized, and people who have some challenges in adjustment, as somebody said, irrespective of income, literacy is not, just I think somebody said, health literacy is not restricted to third graders, the lack of it. I think as a strategy, I support that very strongly. We're talking about families and people. And public health historically specializes in that. Educating, teaching prevention. But recently our health department told us about 5 years ago that in addition to the traditional public health strategies, we've got to look at the total environment in which people live. They told us it's just not enough to do the brochures and the literature. And that's why we put housing and jobs, training and placement in our $1 million health center out here in Adamsville. Not just WIC, but jobs and housing, because the person who comes for that WIC is a total person with a lot of different needs. So I don't see a missing link. I learn every time I come around the health services folks. I learned a lot today. Our Office of Environmental Justice staff person is here this morning. She keeps the information coming to us. And so I don't see any missing puzzle. I just think we have to get down to business, be committed, and understand that the only legitimate test of what we're doing is quantitative.
Great. Sarah?
I'll try to keep this brief. I just wanted to touch on a phrase that Nazira uses quite often, which is connecting the dots. And just stress once again the disconnect of tracking what's going on with your child from a month-to-month basis, a year-to-year basis, when you're dealing with children who have asthma for years. And you know, it's a great idea, I think, to have parents journal, bring printouts from your pharmacy to show how much you've been refilling your rescue meds, or you know, point out, have a discussion about how long you've been on this preventative medication. Why are you still on it? Why is it not working? If it's not working, why are you still on it? And tracking, unfortunately, the death rates would be a huge help. When I first came to this summit 2 years ago, after making the phone call to Nazira, when I read the article in the newspaper about her asthma coalition, and I met Helen Molden's mother, Rhonda, I had to thank her for having a bill passed in Georgia that allowed my children, both of my children, carry their inhalers to school, keeping it in their backpacks, keeping one in the nurse's clinic, so that we had one at all times. There was one at school. When I picked them up, there was one in their backpacks. So if we went to after school activities, we always had one. I had one in my purse. But unfortunately, the death of Kellen allowed Brennan and my son Dalton to carry their inhalers to class, to school, and to go to their nurse clinic and say, my chest is tight, or I wheezed, or I feel like I need to use my inhaler. So I really have to thank her for taking on that mission, having something accomplished. And again, for Tim and I, you know, we want to take on a mission for Brennan, because unfortunately, her death has gone unnoticed by a lot. Asthma doesn't discriminate. It doesn't care where you live. It doesn't care what hospital you show up in. And you know, we found that out the most unfortunate way. And you know, we just want to see better tracking in place as far as medications, doctor visits, you know, just the entire package, just connecting all the dots when you have a child who has chronic asthma.
Thank you, Sarah. Sandra?
I think the only piece that's I don't know if it's missing, but needs to be on the forefront, and that is people being mindful of when you are communicating. And this is not to suggest talking down to people, but just be mindful of the fact of the literacy level. That's just real simple. I mean, I'm challenged with some literacy issues around finance or my car, or you know, it's no brainer. So when you're talking to people, particularly around trying to manage chronic illness, just be mindful of the words that you're using. You know, I heard particular. allergens, bronchospasm. Those are many multiple syllable words. There's a great website called Ask Me 3. Just Google it. And it's a National Patient Safety Foundation that put this out. And it's designed to improve communication, encourage patients to be more active, and to improve health outcomes. And they boil down 3 main questions that you should ask. What is my problem? What do I need to do? And why is it hard for me to do it? I love when Lynn said, when students show up in the health services, and they ask them to show the nurses, how are they managing their asthma? Every moment that you have with someone is a data moment. You don't need a large sample. You just need to capitalize on that opportunity to say, okay, are we communicating here? That's incredible rich data, because at that particular moment, that could impact an understanding of how they're managing their asthma. It can improve their health outcomes, and it reduces costs. It improves relationships. It makes the patient more confident, more comfortable. And so, again, I think the only missing piece is to be mindful of health literacy.
Lynn.
Well, I have so much to say. I could have done this conference all by myself in the 4 hours, and I just had so much to say, and I'm going to try to wrap it up as succinctly as I can. Let me just say this. I agree so much with Commissioner Darnell. I don't think that it's so much of a missing pieces issue as it's a big puzzle that's scattered, and we just need to continue to put the pieces together. Because the pieces are there, the resources are there, the knowledge is there, the talent is there. Every day we learn something new, so we can always bring those pieces to the table, but there's a lot of stuff that we already know. There's a lot of things that we already have. And from the school system standpoint, let me just say this. Sometimes we have a very, we have this perspective that school nurses sit in clinics and give out Band-Aids. It's so much more than that. It is so much more complicated now than that, because our children have so many more complicated illnesses and health issues than that. We see the faces of a Brennan every day, and we take those beautiful faces very, very seriously, and we take our jobs very, very seriously. So part of the puzzle that I think that the pieces that we bring as a school district is, number one, that we take care of these kids every day. And we do it to the best of our ability. But what does that entail? That entails us to make sure that as school nurses, we're prepared and we know where these resources are. So when we talk about missing pieces or pieces that need to come together, there's continued dialogue that needs to happen about regarding where the resources are. When I look at some of our data, and yes, school nurses track data, I can tell you exactly for the last 10 years that I've been in this position, how many children we have with asthma in our school district, how many doses of medications we give to these children, what types of medications that they're on. And so when I look at my data, I know exactly where our children, where our highest population of kids who have asthma, where they live. And Commissioner Darnell is absolutely right. Most of our cases are in that South Fulton lower area, almost to Douglasville. So what have we done as school nurses? We partnered with other resources and people outside of our school district. We don't just stay in the clinics in the schools. We go outside of the Fulton County school wall. So and I'll give you a real example about, what was it, Richard, about 3 weeks ago? Richard actually came to my staff meeting because I make sure my nurses are kept abreast about particulars, data, information. How can we help our children that are in our school system? So one of the missing pieces, and I want to make sure I get everything, is just pure access to care. When I think about my children in South Fulton, the nearest children's hospital is Hughes Spalding. Many of my families that live in South Fulton are on public transportation. That's very difficult to get to Hughes Spalding. If we go even further south, the nearest hospital is Piedmont Fayette. We don't even have a children's hospital in South Fulton. So we have to come, again, that's a barrier, that's an opportunity for improvement. The other one is partnerships and relationships. we make sure, my school nurses and I, that we establish these partnerships. So again, we're not just in the clinic. And again, thinking about that area that we have so many kids who have asthma, we did programs this year. We partnered with the American Lung Association. And I'm proud to say my school nurse who worked on that initiative is here today in the audience. Wave your hand, Ms. Hicks. She spent hours, weeks coordinating a program for her children, for her families, with the American Lung Association, so that we can bring additional programs and services to children in the community. The third thing is continued education. I have a master's degree in nursing, but I learned so much this morning. Just information that was reiterated, that was good information that we can take back to our parents. Remembering things like literacy rate, remembering things like the black box warning, that I can remind my parents to say, even though you get this box, and we're going over this information, it's really, really important for you to ask the pharmacist questions about such and such. And if you need some help, come back and we'll try to help you, again, to the best of our ability to explain that information. So from our standpoint, I just want to leave on this note that for the school district, we're here to support this effort. We're here to take care of the children to the best of our ability. But we too are one of the partners in this link, and we certainly want to be a partner in the link. So if there are things that the community thinks and feels that we can do better in the school system, I am always a phone call away. Our information is on the website. Send me an email. Give me a phone call and say, Ms. Meadows, I think I have this program. We'd love to partner with Fulton County Schools to do this. Or here's some information that I think would be helpful for your school nurses. I would appreciate that. So thank you.
Great insight, Lenny.
I'll echo. I agree with the panels in terms of some of the missing pieces. From my experience, I think the missing piece that we have is just sheer awareness. And before the Atlanta Housing Authority, I actually worked for CDC, and most of my assignments were in Africa. And what I've noticed is that CDC does a very good job mobilizing overseas. For example, there's something called NIDS, National Immunization Days, when you take your children and they are vaccinated from polio and measles. But it's more than just vaccination overseas. There's also an educational element as well. We do not see that educational element here. And my point is, why are people overseas are mobilizing and learning about chronic diseases in these impoverished societies, and here in the developed world, we are struggling and mobilizing? So is it a federal government issue? Is it a community issue? I think it's a combination of both. So I think the missing piece is simply awareness. Information sessions. Back in 2008, I lost my dad to pancreatic cancer. Happened very quickly. But I'm not seeing awareness sessions. I'm not seeing information sessions regarding pancreatic cancer, which is probably the most lethal cancer. In other words, we don't know much about it. People die, and it's one of those cancers that we're trying to maybe do more in terms of research, but what have we done in the last 10 years about pancreatic cancer? So my point is, I think there's lots of gaps in our healthcare system, period. And I think we can learn a lot from working with EPA, for example, and also CDC. What are their strategies in mobilizing people overseas when they have the National Immunization Days in Kenya, for example, in August? And then September and October, you have so many people who come and they want to be educated. We don't see the same effects here in the States. So I think, from my point of view, and this is based on my experiences, it's awareness, community outreach, information sessions, and the whole educational component, I think, is missing. And it's unfortunate, but I think we have a lot more work to do than we have done.
Thank you so much, panelists, for all these, either the missing pieces or we have the pieces together and how do we put together. Please know that Carla is actually recording this session, so you will have a video, a CD out of this session. So Commissioner Donald, you're not going to miss any notes. You'll have the video version of this panel discussion. We'll just go through quickly a couple of questions, and then the lunch is also ready outside. So Andrea from the State Department asks a question, does the Asthma Coalition collaborate with the colleges and universities, because it looks like the students are well controlled at their homes, but when they come to the college, they don't have a control over the environment inside, the humidity and the air quality. So does the coalition collaborate with the colleges in Atlanta and around Atlanta?
So for those of you who are still probably trying to figure out what the FAIR Coalition has been doing for the last 2 years, probably capacity building is the word I would use to describe it. And Naziris, you gave a great question, do we collaborate? We're actually in the process of collaborating with Georgia State University with some grants around capacity and also gathering data to support strategic initiatives. I think Commissioner Darnell talked about in terms of quantitative information, but qualitative pieces of information both are needed to support a strategy. And the strategy has to be based on the greatest return on the investment. And I don't mean profits. I mean being very strategic, identifying who do you need to work with to design a model that would support the outcomes, the best outcomes in the most accelerated fashion. So to answer your question, yes, we are, and more of what that project looks like will come out as we grow and cultivate relationships.
And I guess this question is directed towards Richard. Are there any respiratory therapists involved in your coalition in teaching asthma education?
Yes, there are. We have one of the original founders of the Asthma Coalition was from Georgia State, who was in the pulmonary group there with a number of respiratory therapists. We have Dr. Galena, who's now retired from Emory, who has brought us to the attention of a number of the people there. And in fact, Dr. Galena is working, I believe, with Sarah here to set up a program whereby those children that are at most at risk will be able to go into their homes, with their permission certainly, to go into their homes and do an evaluation of their indoor environment and find out what kinds of things are affecting them that can be tied back to the pulmonary group that they can help. And I wanted to make one point about that. When we're talking about the emergency care and the method and the numbers of emergency situations that exist, we don't have to solve all of the problems or eliminate all the triggers for asthma, for emergency room visits or for serious asthma attacks. It's kind of like filling a bucket up with water. You get some from your food, you get some from outdoor, some from indoor and all that, and the bucket overflows. If you can remove any of those things from your environment and reduce the load on your immune system is far better able to handle the rest of it. So we don't have to solve everything in order to make a significant difference in that component of emergency care.
I think I'd add to that, again, about strategy and being very targeted. Christina related, you talked about indoor air and understanding exactly what the cause of the reaction or the asthma attack. I don't want to say the word exacerbation, who would know that, right? But we have to be very strategic. And I think if we identify the triggers, the causes of those triggers very specifically for that particular patient that deals with asthma, we're more likely to improve the health outcomes. And we got to think about it from a global perspective, but then drilling it down very specifically. We already know the targeted audience, what's needed and what's necessary for that community to support improved outcomes. The other piece to this is we need community involvement. You have all these alleged experts here, outside of Sarah and Tim. We need someone involved on the panel, Varnell, to be able to provide feedback exactly what's going on in their communities based on the Beltway that they're dealing with on a day-to-day basis. That's key.
Great point. Thank you so much. And I guess the coalition is made up of the community members, researchers, and healthcare providers coming together to create solutions and a forum to make things happen, right? So we do have all your questions. We're going to make sure that we answer all of these questions when we send up a follow-up email. And I'm directing Kara, my team member, to make sure that we have them all answered and we send out the email. And you heard it all, folks, today. Again, we might not have it all solved or resolved today, but we are here. We are talking. We started the dialogue. Atlanta Housing Authority was not there 2 years ago, but now we have their attention and they have ours. And collaboration partnerships are very rewarding, and especially if the overarching goal is centered around patient-centered improvement outcomes, health improvement outcomes. That's the ultimate that we received. So there are 4 sessions in the afternoon. We hope you would stay and attend these sessions. One of them is by Richard. He's going to focus on indoor air. And other one is how do you get access to data, presentation by the Morehouse team. And for those who have family members with asthma, there's a team presenting on the inhalers and spacers and the new device techniques that is available to manage asthma. Apart from that, lunch is served outside. If you can go through this door, the door here towards me, and then come back to the other door from the back, that'll be great. So thank you so much for being here attentively, and I hope you enjoy your lunch. And we do have our panelists, they'll stick around for a few minutes in case you have more questions to be answered. Thanks so much again.